Thank you and good afternoon. We just got off the floor and it's 12:55. Welcome to the Health and Government, Public Health and Minority Health Disparities Committee. It is 12:55. We have hearings at 1:30. We may run a little 5 or 10 minutes later. The chair gave me flexibility if need be. We have 3 bills and then, we have to go back to the floor this afternoon as well. So we'll get through it. We have Senate Bill 96, House Bill 934, and House Bill 537. We, as you know, this committee is very open, so we always let the sponsor and advocates know, and I welcome everyone. This is the time to ask questions. We're going to start with Senate Bill 96, Public Health, Behavioral Health Programs, and Healthcare Facilities, Safety, and Community Relations Plans. Erin, if you will be so kind.
Senate Bill 96 specifies that regulations adopted by the Behavioral Health Administration must require a behavioral health program to establish and implement a safety plan for the safety of individuals served by the program as part of the requirements for licensure. If a program is required to adopt a community relations plan as part of its accreditation, the program must submit the plan to BHA. The Department of Health, before approving the operation of a facility or granting a license, must require a facility to establish and implement a safety plan, and if required by the accreditation organization, to establish and implement a community relations plan.
And for the committee, Erin sent you everything you need to do the work today. It's in your emails with the bills and amendments. So we have Delegate Sheila Ruth. You can go ahead and address the subcommittee. I know we also have other people that Erin will remind me shortly for this bill. Good
Delegate, this is not Delegate Ruth's bill. This is Senator McCray.
Oh, so sorry, I forgot. See, I have you on my mind, Delegate Ruth, because I'm rushing. So, Senator, this is for Senator McCray. We just heard this bill this past week in committee, so I know it's fresh in our minds. Is there anyone from the department here? When we let them know, anyone that would like to speak on the bill? I know that Delegate Robin Lewis asked a fabulous question last time we were in committee about the need for the bill and what it did, that it basically informed the community of this plan and it gave them an opportunity to be aware. Correct, Delegate Robin Lewis? Can't hear you, you're muted.
Yes, ma'am. Thank you so much, Madam Chair. I think you summarized my question perfectly.
Okay, wonderful.
It would be great to get the answer.
Well, are there any questions from the committee regarding what Senate Bill 96 does?
I have my hand up.
Oh, sorry. I did not see you. Go ahead, Delegate.
Thank you.
My pleasure.
Did we get any amendments or additional information from the Maryland Psychiatric Society or the Washington Psychiatric Society with their concerns?
We did not. Erin, would you like to address that?
I know that they submitted written testimony. I sent the link to people, but
so if I'm reading their concerns correctly, I think this bill is about methadone clinics. Is that right?
Behavioral health programs. And this was supported by the Maryland Association for the Treatment of Opioid Dependence, which are the clinics who would fall under this bill.
Yeah, I think the impetus of this bill is for methadone clinics and trying to find a way. I mean, I get where Senator McCray is going with this, and I understand the challenges of having methadone clinics and the impact on the neighborhoods. I'm just it's interesting that we didn't hear anything back from the Maryland Psychiatric Society with some kind of amendment or something we could do that would mitigate their concerns. And they said the bill reinforces stigma and unwarranted fear of individuals presenting with mental or other forms of illness by suggesting that every facility which treats these individuals must protect the community from them. So I guess there, without any offered amendments, I'm not sure.
Yeah, there were no offer amendments, delegate, and where they're coming from, in all honesty, we heard this last year, we heard it the year before, is that a lot of these clinics are in certain neighborhoods only. And basically they were trying to say that by having these type of bills, you're preventing these clinics from coming into the neighborhoods, and that it basically suggests that the clinics are violent. But I did talk to the senator, and I encouraged the senator to work with a lot of the, behavioral health and a lot of these clinics, and he did. And what you have in front of you, delegate, is a compromise, basically a compromise language, and the bill basically requires safety plans for client and staff behavioral health programs to be submitted for state licensure. These plans are already being done. They're not being replicated. They're doing it already. So it's just another step. And this was a compromise. And with that in mind, the supportive stakeholders, which are HFAM, the Maryland Association for Treatment of Opiate Dependence, they basically all supported it because he worked on it in the interim. So I don't.
Yeah, I wouldn't sure I could characterize it as a complete compromise because everyone's not on board. And I'm not saying I'm opposed to the bill. I support the bill. I just was asking questions. So
Yeah.
Compromise with some of the parties, Madam Chair, but clearly not all of them. So.
But what I'm trying to say, and I respect what you're saying, is that there's not going to be a compromise with the Psychiatric Society. They're never going to come on board because they just don't agree with the concept, is where I'm getting. And I know because I was intimately involved with him getting, trying to get the right parties to the table. And sometimes we do compromise, but sometimes we won't. And an issue like this, they're not going to compromise on it. So it's tough. So I do appreciate you bringing that up, but they didn't give any amendments in their letter. We have Delegate Hill and then Delegate Riley.
Thank you, Madam Chair. I think this was as I understood it, and as Delegate Lewis is the answer to her question. So we've had a number of issues in the past several years, whereas different types of health clinics have opened up in neighborhoods have been concerned about how much information they did not have. What I read in that opposition, since we're having the discussion, was the concern that if you allow that communities are entitled to have information, that it's somehow furthering the stigma that these places are dangerous. So they weren't so much, as I read it, against, they were concerned about, does that reinforce what we're trying to dispel? And as you said, there's no compromise there. That's got to be their position. Are we making the stigma worse? But I thought what Senator McCray said is because they changed the bill so it did not specify that only methadone clinics, but every type of health facility, whether it's any kind of behavioral health, whether it's, for non-behavioral health, non-addiction issues, if it's a health clinic going into a community, disabilities, whatever, that they should make sure that the information that they're already gathering is also reported to the licensing group. And I thought that was his answer, is we're lifting the stigma by not isolating them in this requirement.
That's correct.
All right, thank you.
Yeah, he worked on it to make it general, right? Not just to a specific clinic. And that was the point of contention in the past regarding the question that was asked by Delegate Rosenberg regarding whether, it was constitutional or not. It was because it was so prescriptive. So making it general and broad, then it takes care of that. Beautifully put, thank you. Delegate Riley.
Thank you, Madam Chair. Yes, Delegate Schlagen mentioned part of the opposition letter that we received, but they went and they had an additional opposition portion in the letter that talked about possible liability issues for the clinic under certain circumstances, and also the problem of possible driving up the costs of mental health at these clinics? Was that addressed, or do we have any answers on that?
Go ahead, Erin, before I speak.
Okay.
It was not addressed because they just submitted the written testimony, so.
Okay.
And the fiscal note, if I may add, Delegate Riley, the fiscal note state that the bill does not, have any significant fiscal impact. It's in the fiscal note as well. And these plans are already being done. They're done already. They're written already. It's just another step to share it with the state when they're getting licensed. So, this is something that it's already done and require. It's just an extra filing.
Okay, well, at this point, I may, since, I don't really have answers from, directly from these folks, I would like maybe the opportunity to maybe give them a call or something to see if they've, what they were talking about here, since it doesn't specifically address their actual issue. I don't know if they just, pulled it out of the blue. Do we have anybody? And you already said we don't have anybody here. Okay.
No, they're not, as Delegate Hill said, they're not going to submit an amendment because it's just a philosophical
Gotcha.
difference, and you
Okay.
can compromise when there's a philosophical difference.
Okay.
And the fiscal note says there's no fiscal, fiscal impact as well. It's a matter, it's a philosophical, it's a difference in perspective.
Okay, thank you.
My pleasure. Delegate Robin Lewis and then Delegate Rosenberg.
Thank you, Madam Chair. I wanted to draw everyone's attention to another feature of the bill that I think is important, and one of the intentions that Senator McCray had in conceiving the bill. One of the requirements of the bill is that behavioral mental health facilities offer a community relations plan with their licensure application, and further that they share that community relations plan with the communities in which they're situated. I think that's really important, and if I may, Madam Chair, I'd like to share with my colleagues why. Thank you so much. Behavioral and mental health clinics that are situated in industrial parks and off highway exits don't have neighbors really necessarily to deal with, but those facilities that are situated inside residential communities do have neighbors, other businesses, and people who live there. And these facilities can be wonderful neighbors. I happen to live 1 block away from a residential housing facility. That's one of the best neighbors that we have. We were really worried about them when they came to my block about 10, 12 years ago, but they're absolutely one of the best neighbors. But not every facility is able to sort of assimilate, blend in, add to the quality of life of a place. Community associations, neighborhood associations frequently express frustration with some facilities. They find it difficult to communicate with the operators to get answers to questions about challenges, that come along with the services that are offered. And Senator McCray's bill helps to address that by requiring, as part of licensure, the establishment of a plan. This facility will, for example, post its hours of operation publicly. This facility will send a liaison to the monthly neighborhood association meetings to keep lines of communication going so that we can all be good neighbors. And those are really simple steps that facilities can take if it's required in licensure, and they're required to also share that with the community. We will have gone a long way to building a framework for good communications and neighborliness, which is really essential, not just for the effective operations of a behavioral mental health clinic, but also for their participation in the life of the place where they are. So with that, I'd just say, I think this is a good bill.
And
it's
if I
also-
may, just to add to what Delegate Robin Lewis stated, if you look at page 2 of the fiscal note, it says, since most healthcare programs and facilities are required to have a safety plan in place for another purpose, it is unlikely significant resources will be required for programs and facilities to meet the safety plan requirement under the bill. Likewise, since facilities are required to establish and implement a community relations plan only if required by an accreditation organization, significant resources will not be required for facility to meet this requirement. It is also anticipated that significant resources will not be required for behavioral health programs to submit their community relations plan to the Behavioral Health Administration. In addition, if you read the letter from Health Facilities Association of Maryland, which is one of the parties that is supporting it, although they will be affected, it says, quote, community engagement is good for the health of all involved. It's good for business, whether for or not for profit, and it's simply just the right thing to do. For reasons we support House Bill Senate 96, Senate Bill 96. We also have Delegate Rosenberg.
I would just, thank you, Madam Chair. I would just echo what Delegate Lewis just said. I know as legislators that we deal with neighborhoods back home who have concerns whenever a health facility for the mentally ill, for drug abuse, so on, comes to the community. And I think this bill is a very, very important balancing act and a very important first step towards having a good relationship between providers and their neighbors and doing it in a manner that is consistent with the Fair Housing Act and the Civil Rights laws, which has been a factor heretofore and still is the law. But this is a good balanced way to address the problem. Thank you.
My pleasure. Any other questions or concerns from the committee members? And I do appreciate all your questions. It has allowed us to really go deep into the bill and understand what it does. And I appreciate it. Any other questions or concerns? Seeing none, may I have a motion on the bill?
Move the bill?
May I have a second, please?
Second.
It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition to the bill?
There's an increase to the summary ejectment charge to
I see none, is unanimous. Thank you for the discussion. It's really welcome. Next, we have House Bill 934. Committee members, is titled Public Health Chief Medical Examiner Autopsy Findings and Conclusions. May I ask respectfully, Delegate Lewis and Rosenberg, will you be so kind and lower your little pen so that I don't make a mistake in a minute? On you, okay? Thank you. Aaron, I would like you to read what the bill does and then also the court case, the reference to this bill so that the committee members know why the bill was introduced.
Okay, the bill explicitly authorizes a person in interest to appeal a denial by the chief medical examiner to collect.
1 second, Terry, could you, excuse me, Delegate Hill, can you, 1 minute, thank you. I'm sorry, now we don't have the feedback. Can you start again, please? Thank you, Delegate Hill.
Sure. This bill explicitly authorizes a person in interest to appeal a denial by the chief medical examiner to correct findings and conclusions on the manner of death to the Secretary of Health, who must refer the matter to the Office of Administrative Hearings. Delegate Bartlett is here on this bill, and Delegate Bartlett, either you or I can discuss the findings of the court case. Just of note was that this is based on legislation that passed in 1992, and during the Attorney General's review of the bill of the law, found that the corrections that are sought in this bill should have been done back in 1993 as a corrective matter.
And we never did. Delegate Bartlett.
Thank you, Madam Chair. I just, I bring this as an attempt to clarify what we didn't do in 1993 when we were in session. So it's a clarifying bill. The family or the person in interest has the ability, as Aaron said, to appeal the medical examiner cause and manner, as you will see consistently in the bill, except when it comes to section 2, small Roman numeral I, where it does not state that if the examiner denies the request, that they can also appeal the cause and manner. This was concluded as an error, but in doing all the years that have come since 1993, as you will see in the fiscal note, cause and manner are actually used sometimes interchangeably. And in fact, the Office of the Administrative Hearing states that that they actually, it states that they actually, hold on, this is in fiscal note on page 2, paragraph 2 and 3. I just wanted to give you that under Bill's summary. It states that what the procedure is. It also states under state fiscal effect that the Office of Administrative Hearing advises that the bill changes are merely clarifying and that they already handle appeals for both the cause and manner of death under current law, and further advises that appeals of this type have historically been low. In fiscal 2019 and 2020, there were no such appeals, and in fiscal 2021, there have been one such appeal. So I just wanted to point that out in the fiscal note. And in all fairness, I'll even bring up the letter of information that was presented by the health department, in which they advised that they investigate approximately 500 suicides each year. They gave a figure, however, they do not have anything to support that there has been at any time anywhere close to 500 appeals. And so with that said, I argue, and the fiscal note also indicates that there will not be a significant state impact, fiscal impact, as well as I believe the same.
And Erin, can you read from the case law, the paragraph where it states that it wasn't, it needed to be fixed, please, for the committee?
And if Erin doesn't have that handy, do you have it? If not, I can tell you what page is on.
What I said about the attorney generals, or what the judge wrote?
What the judge wrote.
Okay. So he said, if the intent of the statute was to exclude the manner of death determination from the appeal process, there would not be a path or a process to challenge manner of death determinations to ever reach the secretary, the OAH, or the circuit court. Without any discussion or indication of an intent to specifically exclude the manner of death from the appeal process, the legislative history is overwhelmingly clear that House Bill 565 was drafted and passed to address precisely the situation presented by the appellant.
Sandy, you have anything else to add?
Actually, I had that area circled, and I was going to read that as well, so thank you very much. I just want to say one other thing, and that is that the entire purpose of OAH is to hear appeals of executive branch administrative agency decisions. That's their purpose. So, so it's very important that that the law clearly indicates that cause and manner is what the person of interest is appealing, and what they have, and what the court has a right to review as coming from the Office of the Medical Examiner. So thank you.
My pleasure. We have Delegate Riley has a question, but before we go to Delegate Riley, Reverend Morris, would you like to be heard briefly on this?
Thank you for the opportunity, and good afternoon. I just want to quickly say that first, I appreciate everyone's efforts on this bill. I think that my current case in reference to my daughter is what has brought this to the forefront. I want to say also that I believe that there was an agency failure, and this has taken 9 years of my life. We're coming up on the anniversary of Catherine Morris's death on May the 6th. I think there was an agency failure 5 years ago that I wasn't heard at an administrative hearing. And I spent the next few years in court with pleadings called a writ of mandamus. We're almost 500 pages, just trying to get a hearing over this or get something to be moved. And then once we were on our way to that point, they kept telling me for 3 years in 3 different court cases, the way that you should be heard is through an administrative hearing. Then I finally get the administrative hearing 5 years later. Then on the way to the hearing, they switched up and said, no, you're not allowed to have an administrative hearing. And then we got past that. So with all that, I'm wrapping that in to say that this amendment is so needed, and it may affect somebody else's life, but I appreciate the efforts today and do pray that you all will let this go forward as needed. Thank you very much. And my daughter's name is Catherine Sarah Morris. Thank you and God bless you.
Thank you. And thank you. I'm so sorry. The committee is really sorry for your loss. Okay. We appreciate your testimony. Delegate Riley. You're muted. You're muted.
Thank you, Madam. Sorry.
My
Thank you, Madam
pleasure.
Chair. Ms. Morris, for your story. I do remember that in the bill hearing. So I understand the intent of the bill, and I do agree with it. But since there is a little bit of a discrepancy with the department letter of opposition and with their, like you said, the large figure of 19,300 per case. I mean, that really adds up if we had a lot of people coming in. And now, would you think that since we now are making it law, that it would encourage more people to come forward and do the appeal? So could we possibly put maybe a sunset on this for a little while to see, how many people do come forward, or it's just, a thought?
We could put a review, not a sunset. A sunset ends it, but we
Okay.
could do a review. If you like, for the next 3 years or so, we could do a review.
Okay.
Is that okay?
Okay. That would be great.
Wonderful. Erin, will you be so kind and draft a review language for the bill?
Like a review of how many times since passage of this law that a manner of death was appealed. Or we could even do appeals on cause and manner for 3
Yes.
years prior, post enactment of the bill.
Yes, so that we know to see
Back
what
to you guys.
every year. That's right.
Okay.
And,
Yeah.
and Madam Chair, if I may say one thing.
Yes.
And this is right in line with my conversation with the Office of the Chief Medical Examiner, because I asked that question and I wanted to have more data going forward. And they did, in fact, say that they were going to make sure that they started collecting this data going forward. So this is not putting any, unusual burden on them. So they were already expecting to start doing that more.
Thank you.
But thank you. I think the language is a good idea, Delegate Rice.
Yes.
And if you can make sure, Erin, that is sent to the Health and Government Operations Committee, and what other committee it goes across the street, so our members can read it. Thank you. Any other questions or concerns? Seeing none,
Madam Chair, I also would need to add a clarifying amendment.
I forgot about that.
That's okay. Page 2, line 17. After cause, I think we also need to add and manner there.
Okay, wonderful. I agree. So on both amendment, well, let's take them separately. So just to be fair, okay, to you all. On amendment that Delegate Riley suggested to put some reporting language for the next 3 years or so to be sent to the committees so we can have the information. May I have a motion on that amendment, please?
Move the amendment.
It's been moved. It's
Second.
been second. Any question on the amendment? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none. Thank you, Delegate Riley. On the second amendment, dealing with the clarifying amendment, the legal counsel says that it's needed. Is there a discussion on it?
Move the technical amendment.
Thank you, Delegate Shalega. May I have a second, please?
Second.
It's been moved in second. I appreciate it. All those in favor say aye.
Aye.
Any opposition? Seeing none. On the bill as amended with both amendments, may I have a motion, please?
Move the bill as amended.
May I have a
Second.
second? It's been moved in second. Is there any discussion on the bill as amended with both amendments? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, thank you so much. It passes unanimous. Thank you, Delegate Bartlett. Thank you, Reverend Morris. You have a blessed day.
Thank you, committee. Thank you, Chair.
We have one more bill and we can get you out of here really fast. And the hearings will start at 1:40, by the way. They're giving us a little extra time. We are down to House Bill 537. Delegate Ruth, welcome to our committee. Erin, will you be so kind and tell myself and the committee what the bill does, please?
You have a reprint that was provided by Delegate Ruth. If you go to page 3 of the reprint, current law requires that authorized petitioners who are petitioning to emergency evaluation of a patient to give the petition to a peace officer. This bill would alter that statute by providing that a petition for emergency evaluation, when that petitioner is a certain healthcare provider, that they may take the emergency evaluee to an emergency facility, or they may give the petition to another physician, psychologist, clinical social worker, licensed clinical professional counselor, clinical nurse specialist in psychiatric and mental health nursing, psychiatric nurse practitioner, licensed clinical marriage and family therapist, or health officer, and who will then take the emergency evaluee to the nearest facility, or they can give the petition to a peace officer. If you move on to page 4 of the reprint, a peace officer shall respond promptly and assist in the transportation of an emergency evaluee to the facility if requested. Moving on to page 5 of the reprint, the petitioner is required to hand off the emergency evaluee to a healthcare practitioner who's licensed under the health occupations article before they leave the emergency facility. There are also amendments that would extend the current immunity that's granted to police officers to the petitioners who are included in the bill.
Thank you. Delegate Ruth, welcome to our committee. Could you please address us?
Thank you, Madam Chair.
My
Thank you
pleasure.
for this opportunity. This bill is at its core about reducing contact between police and people in mental health crisis, because we know that the police aren't always the best equipped, even when they've had training to deal with people in mental health crisis. And, you know, a week's training just can't match the years of experience and knowledge and education that a mental health professional has. So our goal was to leave it to the discretion of a mental health professional who knows best the situation, who may know the patient, may have been treating the patient, to use their professional judgment in determining whether the police need to be called in any given situation. We're not removing the police completely. We did submit clarifying amendments because that wasn't clear in the original bill, and in the reprints, you could see that this really clarifies the process. This only applies to when the petitioner is a mental health professional, probably already in the presence of the potential evaluee, that they now have the option to transport the evaluee themselves if they, in their professional judgment, think that that's going to be the best thing for the evaluee. They can give the petition to another mental health professional, which would be the case if there was, say, a mobile crisis unit that they could call, or they can continue to call a peace officer. And this bill clarifies that if a peace officer is called, they must respond, because we've heard of situations even, under the current law where the police don't always respond when they're called. So, our goal is to really just leave this to the discretion of the professional who knows best. Really worked with all the stakeholders. As you can see, we submitted amendments that address the concerns of many of them. Unfortunately, we were not able to address the concerns of all of them. In some cases, it's a fundamental difference about whether the police should be involved, and in all cases. And so we've really done our best to address all the stakeholders. Am I frozen?
No, we can hear you now.
Okay, so thank you so much for this opportunity.
Okay, great. Who would like to start first? I know, let me take one and one. So one favorable and one unfavorable. So I'll start with Dan Martin and followed by Aaron Dorian.
Well, thank you, Madam Chair. And thank you, Delegate Ruth, for introducing the bill. I just, wanted to kind of speak broadly to it, just kind of more like letter of information type thing than for or against, Madam Chair, just because, again, we, really support, thank the sponsor for this well-intentioned bill, and we absolutely support limiting law enforcement's role in dealing with individuals experiencing a behavioral health crisis. But mental health professionals already have discretion of whether to call police or not. There's nothing right now that prevents clinicians from taking their patients to a hospital for psychiatric services. It actually happens all the time. It doesn't require an emergency petition. When individuals are willing to go to the hospital, there's no need for an emergency petition, which is by definition filed in response to a dangerous situation. The individual is either a danger to themselves or others, which is why folks reach out to public safety professionals. And so, law enforcement in the state, with or without a mental health counterpart, depending on how the jurisdiction is structured, transport thousands of patients every year on an emergency petition without incident. And obviously that's not 100% of the time. And there are things that we can do and that we should be doing to decrease risk of tragedies when individuals are in crisis interact with law enforcement. Again, we're working to expand crisis intervention teams, working to expand mobile crisis teams and other crisis response services, working to expand training for how to de-escalate situations where individuals are in crisis. But I guess, but the amendments that basically say, a provider can ask for police assistance to transport an individual on an emergency petition, and they must oblige. That's what an emergency petition is. That's really kind of what the statute currently allows. So I just wanted to kind of throw that out there. Like I said, it's not because we don't support the idea of limiting law enforcement's role in dealing with individuals in mental health crisis. Just I think there's a lot of other ways to do it. Just have some concerns with this bill around issues related to patient safety, provider safety, and things like that. And so just wanted to offer that feedback. So thank you, Madam Chair.
My pleasure. I know I didn't know that was your position, so I apologize. Is there someone, it's all right, I want to be balanced. Anyone in favor of the bill besides the sponsor? Can you unmute yourself, please?
Hello, my name is David Averick, and I volunteer with the Social Welfare Action Alliance, SWA, and we have been working closely with Delegate Ruth in favor of this bill, and we're really grateful to her for her work and really grateful to this committee for its consideration. We're also really grateful to our respected colleagues who have expressed concerns and opposition over the course of this process of advocating for this policy change. And we feel that the concerns that are being named are really valid and should be taken seriously. And we do. To Mr. Martin's, concern around, emergency petitions have to do with situations of inherent danger. That is not my lived experience as a licensed mental health clinician. I think that there are times when somebody does pose a risk of harm to themselves, but not to others, when an EP is indicated clinically, because I'm not able to trust that if I left that client on their own, that they would be able to keep themselves safe. And sometimes when there's a relationship between a therapist and their client, they can collaborate and make that decision together to say, look, we need to access inpatient treatment on an emergent basis, and we need to entrust healthcare providers to keep you safe because you're not able to do that for yourself at this time. And that's when an EP is indicated when there isn't a threat of harm to others. And that is the situation that this bill seeks to address. Because, Mr. Martin indicated that, a therapist can take a client to an ER any time, and that's true, but the EP really enables the client, first of all, to access services in the ER in an expedited way, and also enables them to be taken honestly more seriously by the evaluating staff at the emergency room, given the limitations around inpatient psychiatric care. And so for a therapist who feels, look, this person does need to be inpatient, this is indicated for their safety, but calling a law enforcement officer poses either a risk of escalation or the risk of outright harm. It puts us in a bind. And what this law seeks to do is create discretion and say, look, I have a relationship with this client. They have not had a lived experience where law enforcement officers are guaranteed to treat them with dignity and safety, nor is the law enforcement officer necessarily equipped to do de-escalation or do mental health crisis response. And that's when, giving the option to either the clinician themselves or to a mobile crisis unit, the services of which are being expanded dramatically across the state in the near term, to do that transport in lieu of the law enforcement officer. Other feedback that you're going to hear from our respected colleagues include that there will be safety issues in the emergency room for a client who is not accompanied by law enforcement. And, safety in the ER is absolutely a really important issue. And one thing to keep in mind is that the presence of a police officer isn't necessarily going to increase workplace safety for ER workers, period. In fact, the presence of law enforcement may escalate somebody who's already experiencing mental health crisis, because a law enforcement officer is frequently perceived as a threat by somebody who, unlike me, isn't socialized with whiteness and economic privilege, who have experienced law enforcement officers in different ways than I have. May have been exposed to trauma in the context of contact with law enforcement. If I'm in crisis and that's the situation that I'm experiencing, that might escalate me even further. And so the idea that a cop is necessarily going to increase the safety of a situation, that is not my position. That's not my belief. It's not my experience from working with people in different backgrounds.
Thank you. So Dorian, and we are going to have to hold this bill because we have to go back to hearings at 1:40. And obviously there's not consensus. So we have to keep talking, but quickly in about a minute or so. Go ahead.
Sure. Thank you, Madam Chair. Erin Dorian from the Maryland Hospital Association. Our position is we have some major concerns with this piece of legislation, and I won't get into any of them now since I know you all only have about a minute left, but we truly believe that this piece of legislation is premature. We need to look at our whole system of crisis response and responding to individuals in mental health crisis. Right now, the only place to take a person on an emergency petition is to the emergency department, and a full on 60% of those people do not need inpatient hospitalization for their crisis. So we think that while this bill is well-intentioned, and I agree completely with everything Dan would say and everything you would hear from Adrian and Robin, we just think that this bill is a bit premature and should be spoken about in the context of some more major crisis services reform.
All right, so just quickly, because we do have just a minute, is it safe to assume, Robin, that you're also in opposition? Can you unmute yourself, please?
Yes, Maryland Nurses Association. Thank you to everyone for working on this bill. We do have the safety concerns.
All right, Adrian, are you also in opposition?
Yes, thank you, Delegate. We are also in opposition, and we continue to hear from behavioral health providers in Baltimore City about their concerns.
All right, Dan, are you also in opposition?
Yes, on behalf of the Maryland Psychological Association.
Okay, so I am going to hold this bill. I would ask all of you, if I may, can you work with Delegate Ruth to see if you can get to consensus, if you can compromise? As you know, this is what the chair always says, and I don't push a bill that there's not consensus and that has not been worked out. So if you could continue to work with the delegate, I would really appreciate it. Will you do that, please? All right, thank you so much. And I really appreciate you. This concludes our business today and the hearings, and it's 1:40. We have to go to the other link. Thank you so much.
Thank you, Madam Chair.
My pleasure. Thank you, everyone.